So the next question was mechanism of action of topical dorzolamide. We know dorzolamide and brinzolamide, they are very important drugs in the treatment and management of the open angle glaucoma and ocular hypertension. Very important to note here is that the dorzolamide as well as brinzolamide, they are the carbonic anhydrase inhibitors. Okay, so the answer here would be B, that is carbonic anhydrase inhibitors. Now, in very short, let's learn about the various pathways of various anti-glaucoma medications. So, if we talk about the uveoscleral outflow, the drugs which can basically increase the uveoscleral outflow, the most important ones of them is the PG analogs. So, the prostaglandin analogs like travoprost, like latanoprost, the new one that is the bimatoprost and the tefluprost, they are basically the ones which basically increase the uveoscleral outflow, and they are the ones which are having a OD dosage as well as they have 24-hour IOP reduction and maximum reduction of IOP. So the PG analogs are considered to be the drug of choice in the management of primary open angle glaucoma as well as the your primary ocular hypertension. Now the second type of drug, which is the new class of the drugs, is that increase the trabecular meshwork outflow. So these are the ones like your ripasudil and netarsudil. They are under the Rho kinase inhibitors, or we also call them the ROCK inhibitors. Another important mechanism of action of Rho kinase inhibitors is that they can basically decrease the episcleral venous pressure as well. So in those cases where, let's say, Sturge-Weber syndrome or thyroid ophthalmopathy, there also the Rho kinase inhibitors can basically work. Now we have the most primitive ones which are called aqueous suppressants, and you all know the ones which are aqueous suppressants are our carbonic anhydrase inhibitors that I told you is your benzolamide and dorzolamide, and very important one is the beta blockers. So we all know the beta blockers are your timolol, your bitoxolol. So these are the ones which are the beta blockers. Okay, and also remember the alpha agonists like brimonidine, they are also under the category of the aqueous suppressant. So these are the some very short important mechanism of action of the various anti-glaucoma drugs. You can basically refer to our complete lectures for the pharmacotherapy of the medical management of glaucoma there, and if you have any doubts you can ask us. So this was a repeat question. The question was most common ocular manifestation of the COVID-19. So COVID-19 is talk of the town, and very important is you learn each and everything about COVID-19. So as we know, the most common ocular manifestation of COVID-19 is your follicular conjunctivitis. Okay, very important to note here is that the even in any type of viral disease, whether it may be a dengue, whether it may be a Zika virus, the most common ocular manifestation is always a follicular conjunctivitis. Now, mucormycosis can also be seen in the patients of COVID-19, but it is not the most common ocular manifestation. When we talk about the ocular manifestations of the COVID-19, as I told you, the first one which we have to remember is your conjunctivitis, and it can be of many types, but the one which is the most common type, that is your follicular conjunctivitis. Okay, and most of the times remember that you do not need any treatment for this. They are basically self-resolving. Now sometimes you can see episcleritis as well, lid margins, hyperemia as well, but they are not very much common. Very few patients may have a keratoconjunctivitis, a involvement of conjunctiva as well as cornea, but that is also very minimal, and you do not have to go in detail for that. Here for the anterior segment, you should be knowing that the conjunctivitis is the most common ocular symptom. Now we come to the other questions which can be asked. Now remember that these are more common in those patients who have symptomatic COVID. Okay, so let's say patients who are having a pneumonia, or those patients who are having increased WBC count, or basically increased LDH or prolactin. In that cases, we see more commonly the patients of conjunctivitis. Now, remember, COVID-19 is a basically contraindication of doing a corneal transplant. Okay, so this is an important point. We have so many mortalities in COVID-19, but these patients you cannot donate the cornea. Okay, so next thing that you have to basically remember is the posterior segment manifestations. In posterior segment manifestations, the ones which you have to basically know is, because there is a hypercoagulability syndrome that is there, so you can have vascular occlusion most commonly as the posterior segment manifestation. Sometimes there can be a macular neuroretinopathy as well. There is another term which is called paracentral acute middle maculopathy as well. So, but I do not want you to basically remember that. For your exam purpose, please remember that it's a vascular occlusion which is the most common. And remember, these patients are more susceptible for endogenous endophthalmitis because these are now the immunocompromised individuals. Okay, and when we basically call about the neuroophthalmic symptoms, in neuroophthalmic symptoms the patients may present with the optic neuritis, and also there may be multiple nerve palsies also in these patients. Okay, so if you get a short note, who are the third year students, you basically write whatever you basically learn in ophthalmology. There can be something or other here, but do not write cataract there. Okay, now we come to what are the other scenarios which they can ask in your exam. So they can just show you a picture like this. This was one of my real patient, and they would ask that post-COVID hospitalization, patient presented with the loss of vision. The sinus showed this infiltrated mass. What can be the potential cause? So here you know that this can be a patient of mucormycosis. Okay. So remember, more commonly the chances are that they would not be asking about the one-liners. They would be asking about the image-based scenarios or the clinical scenarios. Okay. So last point here is that what you need to remember regarding the orbital manifestations of COVID-19. So it can cause orbital cellulitis and it can cause rhino-ocular cerebral mucormycosis. So these are some important points regarding the COVID-19 that you should be remembering for your upcoming exams. So next question was that we have a table with columns A and column B. In column A, they have given a few of the procedures, and in column B, they have basically put how to basically diagnose that and what are the various indications for doing that. So let's see what were there in the column A and what were there in the column B. So in column A, we had color vision, peripheral field of vision, Goldman applanation tonometry, and hypopyon. And in option B, we have fungal corneal ulcer, IOP measurement, Ischia chart, and perimetry. Okay, so let's see first of all that color vision. So out of them, the color vision can be basically diagnosed with the help of Ischia charts. Okay, so let's see what was there. Color vision was with the Ischia chart, so I write it here. One goes with C. Okay, then we have peripheral field of vision. So peripheral field of vision, we all know, can be diagnosed with the perimetry. Okay, so here we have perimetry like your Humphrey visual fields, like your Goldman perimetry. Okay, then Goldman applanation tonometry, what we do with that, we do the IOP measurement with that. Okay, it is the gold standard for the measurement of the intraocular pressure. We know the normal intraocular pressure is between 9 to 21 millimeter of mercury. And hypopyon can be seen in the patients of fungal corneal ulcer, or then any type of corneal ulcer you can have a hypopyon, but basically in fungal corneal ulcer you have more thick type of hypopyon. Okay, so peripheral field of vision 2 goes with D, Goldman applanation tonometry 3 goes with B, and 4 goes with A. Okay, so we have 1C, 2D, 3B and 4A. Okay, so the answer here would be B. I think very simple question, not much doubts here. Next question was where they have given a picture of the eyelid of a patient and they have asked what is the diagnosis here. So first of all, let's see this more clearly. Here you can see that there is the attachment or there is an addition between the mucous surface of the upper and the lower lid. Can you see it here where we have basically marked the arrow? So this is the ankyloblepharon. So what is ankyloblepharon? Ankyloblepharon is basically the addition of the mucous membrane of the upper and the lower eyelid. So what we have? We have the palpebral conjunctiva there. Okay. So similar type of condition which can also be seen in the conditions of chemical injury where you have ankyloblepharon is called the symblepharon. So how to basically differentiate between the ankyloblepharon and the symblepharon? The first image that I showed you is of the ankyloblepharon, and the second image you can see here where I have marked the arrow. This is basically a symblepharon. In symblepharon, what we have basically seen is that there is an addition between the palpebral conjunctiva and the your bulbar conjunctiva. Okay, so this is the symblepharon. So when we come to the difference between two, so always remember that if we talk about ankyloblepharon, it is the addition between the upper lid and the lower lid palpebral conjunctiva. Okay, and what is symblepharon? Remember, there can be common causes of ankyloblepharon and symblepharon, and the patient may have ankyloblepharon and symblepharon in one eye as well. Okay, so what happens in symblepharon is there is the addition between the palpebral conjunctiva of either the upper and lower lid. More commonly it is seen in the lower lid as well as with the bulbar conjunctiva. Okay, and as I told you, the causes can be similar. The most common cause of the ankylo and blepharon and your symblepharon is the chemical injuries. Okay, your acid attack victims, your patients who are having a thermal injury, there also you can get, and the papillosquamous disorders like your Stephen Johnson syndrome, ocular membrane pemphigoid, and also in the cases the congenital ankyloblepharon can also be there. Congenital ankyloblepharon is seen basically in very small child, and the picture that you are seeing that may be of a patient of a congenital ankyloblepharon. We usually do not see congenital symblepharon, but symblepharon can be basically seen in some of the conditions like trichiasis as well. Okay, so these are the important causes of the ankyloblepharon and symblepharon. A very easy question. So the next question was, which is not the part of the features in keratoconus? Your options were Habstria, irregular astigmatism, scissoring reflex, and Munson sign. So as we all know, the answer here would be Habstria. Now remember, Habstria is basically seen in the patients who are having a congenital glaucoma. Okay, so they are basically the horizontal stria which are seen in the congenital glaucoma. Whenever you have a patient who is having a keratoconus, in the cornea you can have vertical stria, and the vertical stria that we see in the keratoconus, they are called Vogt stria. Okay, so Habstria is in congenital glaucoma and the Vogt stria is there in the keratoconus. We all know the irregular astigmatism, scissoring reflex, and Munson sign are seen in keratoconus, and in the video which is following this you would get the complete knowledge about the keratoconus. Remember, keratoconus would be very very important in your coming exam of the Neetpg as well as for the Fmge aspirants, so please note that. Now I would just show you how the Hab stria actually looks like. So this is a picture is of one of my patient who was having a congenital glaucoma. She was already operated for congenital glaucoma with the trabeculectomy and trabeculotomy surgery. And if you can see the arrows here, so they are basically showing you that there are strias in the cornea, and this is basically called Hab stria. Okay, so we know the Hab stria is in congenital glaucoma.